It's Dr. Silva, and today I'm going to talk to you about borderline personality disorder, one of the big personality disorders, one of the most famous ones, and one that we see a lot in clinical practice, particularly in the inpatient setting. The trainee and the clinician learns a lot from these individuals because we tend to make a lot of mistakes in managing them. The essential feature of borderline personality disorder is that you see a pervasive pattern of instability in interpersonal relationships, as well as an unstable self-image, unstable affects, expression of emotionality, and a marked impulsivity, all of which begin by early adulthood, like the other personality disorders, and that is also present in a variety of contexts. So it's across the board. It's not just in certain situations or in the contexts of certain relationships. Although it is the primary caregiving relationship that is the one that tends to trigger the patient more than others. But they have very unstable relationships, and so what you see is one relationship after another. And separation and divorce is very common among these individuals. A lot of them have been married multiple times. That's actually a sign. It doesn't mean that because someone's been married 4 or 5 times that they have borderline personality disorder, but character pathology is hinted at when you see such unstable interpersonal relationships. That's just one possible sign of that. So according to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition text revision, which is the latest revision of that tome in 2022, you have to have 5 out of the following 9 diagnostic criteria in order to qualify for a diagnosis of borderline personality disorder. And I always want to emphasize, in real clinical practice, we diagnose based on the presentation, based on the symptoms that are there, based on our experience, our own intuition. So I'm not going to not diagnose this if they only have 4 out of these 9 criteria. If the other 4 are unequivocal and the person is having the difficulties and requires the kind of treatment that you would have and that you would require with borderline personality disorder. But officially, for research purposes, you have to have 5 of the following. Number 1, frantic efforts to avoid real or imagined abandonment. So the abandonment is key. That's their key trigger. And it doesn't necessarily have to be actual abandonment. It could just be their perception of abandonment. And there's a note that we don't include suicidal behaviors or self-injurious behaviors that are covered in criterion number 5. But the mere perception of impending separation or rejection is a major trigger for these individuals. It can lead to profound changes in their self-image, their affect, their cognition, which is their perception, their interpretation of events and of individuals, and their behavior. And the examples that are given in the DSM include, for example, the intense despair that a patient might feel when the doctor says, "We're out of time," or the panic or the fury that a person might feel when someone important is just a few minutes late or cancels an appointment, because that leads to that sense of being abandoned, and that implies that they're bad, that they're unworthy of that person's affections and attentions and ultimately their caregiving and their nurturance, because that's really the core pathology, that these individuals are looking for someone to nurture them, to love them unconditionally. And when they don't find that, they can jump to that conclusion that they're being abandoned or rejected with the most minor of slights. This is also related to an intolerance of being alone. Number 2, a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. And this is called splitting, where the individual might switch very quickly from idealizing another person to devaluing them. So when a person with borderline personality meets someone that they attach their hopes of being cared and nurtured by to, then that person hung the moon, the best thing that's come along in a long time. But the moment that that person disappoints the individual with borderline personality disorder, then suddenly when that individual feels rejected, then that person is worthless. They're awful, they're evil, they're terrible. And so that can lead to the cycle of marriage and divorce and marriage and divorce and marriage and divorce that you sometimes see. But you see the person going from being all good, just the best person they've ever met, to terrible, all bad. And they do this over and over again. And they lack the insight to see what they're doing. Now, there's a related term of splitting that's used in an inpatient setting when you've got a treatment team and you have a borderline individual on the unit, where the borderline individual will act out, they will attention seek, and they will cause chaos on the unit. A lot of times in treatment team meetings, we end up spending a lot of time, a disproportionate amount of time, discussing the patient that has borderline personality disorder because of their acting out behaviors, because of their inappropriate behaviors with other patients and with staff members. And so there's a lot of conflict a lot of times with these individuals. They don't want to follow rules and such. And so they will split staff members. And so one staff member will be their hero, just the best nurse, the most caring and nurturing, as opposed to this other staff member is just the devil. And the problem, if a person is inexperienced, if a practitioner is inexperienced, they can get drawn into this idea, especially if they are the hero. And when you begin to feel critical of your colleague, and when you begin to think, oh, they're mistreating this poor patient and they really should do better, that is often a red flag. That's often a sign that you are being split, that the patient is splitting the treatment team. The patient is engaging in this idealization and devaluing of the staff members, but when the staff members start to be affected adversely by that behavior and they're unaware of it and they're not responding in a professional manner, then they're allowing themselves to be split. And so a lot of times in treatment team meetings, we will talk about how the individual with borderline personality disorder on the unit is splitting the unit. But this is what they do. And unlike individuals with antisocial personality disorder or narcissistic personality disorder, they can empathize with and nurture other people. In fact, in the context of their latest idealized relationship, they are more than happy to nurture their significant other, but only with the expectation that that other person will, quote unquote, be there to meet their own needs on demand. And so these individuals are prone to sudden and dramatic shifts in their view of others, but particularly persons who have been idealized, but whose abandonment and whose rejection is expected. Number 3, there may be an identity disturbance. A lot of individuals with borderline personality disorder have this markedly and persistently unstable self-image or sense of self. So you see these sudden and dramatic shifts, not only in their affect and their emotionality, but also in their sense of self, in their sense of self-image, because usually they have this self-image that's based on a feeling of being bad, a feeling of being evil or inadequate, essentially unworthy of this love that they are so desperately seeking. A lot of individuals with borderline personality disorders describe themselves as quote unquote broken. And when I see that, I've seen it many times, patients have described themselves to me and they tend to meet other criteria for this personality disorder. Another distorted sense of self would be the sense that they don't exist at all, which can be very frightening. And it's metaphoric. The patients aren't psychotic, although it may be related to feelings of dissociation, which I'll cover in just a bit. These patients aren't psychotic, but the term borderline was originally coined to refer to the borderline between reality and good reality testing and psychosis. These patients showed such grossly disorganized behavior at times that there was a question as to whether or not their reality testing was intact, and hence the term borderline, which doesn't really have the currency that perhaps it was intended to have. It was named for the idea that people with this condition fall between neurosis and psychosis. It was actually first used in the 1930s by a psychoanalyst, Adolf Stern, to describe patients who didn't fit neatly into either category. He observed that these patients had neurotic symptoms such as anxiety and depression, but as time passed, since analysis didn't cure them, psychiatrists began to think they might be on the psychotic spectrum. But neurosis is not really an official term in the current nosology, and even borderline personality disorder has been proposed to be renamed emotionally unstable personality disorder. For now, the American Psychiatric Association continues to call it borderline. And to think Freudian psychoanalysis failed to cure the borderline individual. Well, it gave us the term anyway, but I think one of the most effective psychological treatments for borderline personality disorder is actually dialectical behavioral therapy. And I'll be following up with a series on that, so please look for that. But according to the DSM, quote, this lack of a full and enduring identity makes it difficult for the individual to identify maladaptive patterns of behavior, and that then leads to repetitive patterns of troubled relationships. And so, again, in the example of the patient who has been married 4 or 5 times, they don't see what they're doing, the splitting that's leading to these quick marriages and the quick dissolution of these marriages because they lack that insight. Number 4, impulsivity. We see impulsivity with, I think, most of the personality disorders. And in this case, in at least 2 areas that are potentially self-damaging. For example, excessive spending, unsafe sex, or indiscriminate sex, undiscerning sex, substance abuse, reckless driving, binge eating, and again, not criterion 5, not actual self-injurious behavior, very common in patients with borderline personality disorder. As a matter of fact, if you see a patient who's had multiple suicide attempts and or suicide gestures, and especially those patients who have also engaged in self-mutilation, cutting behaviors, or burning themselves, immediately you think of borderline personality disorder, and there's a high correlation there. So oftentimes when I see that, unless it's just a very transient period in adolescence, if I see that it's been going on for years or that it's currently going on in a patient who is in their mid to late 20s, almost always the diagnosis is borderline personality disorder. You could almost make it right there clinically. But you see this recurrent behavior, and it's often the reason that these individuals present for treatment. Again, it's usually precipitated by threats of separation or rejection or the sense of same. And this self-injurious behavior can sometimes be associated with the dissociative symptoms that I'm going to talk about in a little bit. Why do patients do it? Well, some patients can't tell you. A lot of patients will say, I don't know why I do it. Does it make me feel better? Yes and no. A lot of times patients are at a loss, but sometimes they describe that the physical pain is a distraction from the emotional pain. So that's one explanation. On a deeper level, sometimes patients can describe that hurting themselves reaffirms their ability to feel, that they do it because they just wanted to feel something. They needed a respite from these chronic feelings of emptiness and the sense that they don't exist at all. And then also finally, and or it's their penance. It's their ability to expiate their sense of being evil, of being a bad person. And a lot of times they're badges of honor. There are borderline individuals who are ashamed of this behavior, and so they'll hide it. They'll maybe cut on their inner thigh or somewhere where no one's going to see it. And that actually, in my experience, carries a better prognosis than those patients that do it repeatedly where other people are going to see with the intention of scarring their bodies. And there are cases, a subset of these patients are those that really do wear them as badges of honor. It's almost like they are marking themselves. I remember this one young man, he had wounds that he had done it so much, and I'm sure he had issues with infection, but the scars were red and deep. It looked like he had done them just yesterday, and they ran all up and down his arms. He had absolutely mutilated his body, and it was one of the worst cases I'd seen, and he was proud of that. It was his way of showing people how much pain he had endured. And so it's interesting when you examine whether these attempts are being hidden, whether they're being done covertly, or whether they're being done overtly. Despite all of these self-injurious actions and suicide attempts and threats and gestures, death is more than twice as common from other causes, including accidents, for these individuals than actual suicide. So you see a lot more of the behavior than the actual completed suicide, although they are at increased risk. Number 6, affective instability due to a marked reactivity of their mood. So, for example, intense episodic dysphoria, irritability, or anxiety, usually lasting just a few hours, rarely more than a few days. So they're labile. Their affect and their mood are very labile, and that reflects the individual's inability, their extreme reactivity to deal with interpersonal stressors. They have a mood that's characterized as basically dysphoric, but it's often interrupted by periods of anger, panic, or intense despair, and this dysphoria is rarely relieved by periods of well-being or satisfaction. It's unfortunate these individuals, it's no wonder that they're constantly engaging in self-injurious behaviors or suicidal behaviors, or these desperate attempts to manipulate others and to hold on to them, or the splitting behaviors, because they're chronically unhappy. They're rarely happy until they get older. Number 7, chronic feelings of emptiness, which can co-occur with painful feelings of aloneness. Patients are easily bored, and they might seek excitement to avoid these feelings of emptiness, and that may explain somewhat criterion number 4, impulsivity and thrill-seeking, even if it's self-destructive. Number 8, inappropriate, intense anger or difficulty controlling their anger. For example, frequent displays of temper, chronic anger, or recurrent physical fighting even. You often see extreme sarcasm, enduring bitterness, and inability to forgive, or verbal outbursts. The anger is often elicited when a caregiver is seen as neglectful, emotionally, withholding, uncaring, or abandoning. And unlike the antisocial personality disorder, these extreme expressions, these outbursts, are often followed by shame and guilt, which then contribute to this feeling of being a bad person. And you don't see that with antisocial personality disorder patients who are bad people, bad, dangerous people. I have another video about that. I encourage you to watch that. But where you see intense anger and acting out on that anger, the borderline individual then very rapidly will default into feeling bad about that. And there's just more evidence, a self-fulfilling prophecy, more evidence that they're unworthy of being in loving, caring relationships and of being loved and cared for. Number 9, transient, stress-related paranoid ideation or severe dissociative symptoms, especially depersonalization. What is depersonalization? Depersonalization, according to the DSM, is, quote, experiences of unreality, detachment, or being an outside observer with respect to one's thoughts, feelings, sensations, body, or actions. And it's ironic because this idea of detaching yourself from your ego and observing your thoughts, observing what thoughts your brain is coming up with, and examining your actions and your motives more objectively, the way a third party might, is actually a goal of enlightenment. It's actually something that you might want to do voluntarily from time to time while you're meditating or just in life as you're going through life trying to manage your anger and trying to be a better person and examining why you engage in these self-destructive behaviors, why you gamble or why you take drugs. It can actually be a good thing. But when it happens involuntarily, when it happens just in the context of being very stressed out, then it's a symptom in that regard, and it's just frightening to the patient who doesn't really know what to do with it. And it can involve perceptual alterations, so illusory phenomena, maybe not outright hallucinations, but there can be a distorted sense of time, a feeling that they're unreal, or absent. That's the depersonalization, or emotional and or physical numbing. And a lot of times they'll describe themselves as though they're outside of their body looking at themselves or maybe floating above, and they're observing their interaction with another person. It's sort of a quasi-psychotic symptom. The dissociative symptoms is the whole section of the DSM, and some of those diagnoses are controversial, especially dissociative identity disorder, what used to be called multiple personality disorder, which some clinicians don't even buy. I'm going to do a whole video on that, on dissociative identity disorder, but I will tell you that while certainly not all patients with borderline personality disorder meet criteria for dissociative identity disorder, in my experience, 100% of patients with quote-unquote dissociative identity disorder, multiple personalities, that I've seen inpatient and in clinics, 100% of them have personality disorders, and the vast majority are borderline. So whatever else, whether you are a practitioner who believes that this is a real diagnosis, that it really exists, or whether it's just something that personality disorders endorse and embrace as part of their struggle with feeling special and their unstable identity, regardless of what camp you're in, there is an association there. And a lot of these individuals with borderline personality disorder have more than just transient depersonalization. So criterion 9 is that this symptom is transient, even if it's severe. So it just lasts for a few moments. Depersonalization is really not going to last hours and hours, but it's episodic. Even if it happens frequently, it is transient. Whereas these other disorders that are dissociative disorders, they are more persistent. Again, these episodes occur most frequently in response to real or imagined abandonment. Associated symptoms. I want to tell you about the teddy bear sign, and this is a real thing. I've seen it more than once, and many of my colleagues have as well. You're in the emergency room, a patient comes in, maybe they've been having suicidal ideations or actual gestures, and they come in holding a teddy bear. A transitional object. A transitional object is an object that children use between caregiver visits. So when mom is out of the room, there's a teddy bear in the crib with them that's going to keep them company. A smiling little face so that they don't feel alone, so that they don't have separation anxiety. That's a transitional object. Think Linus in the Peanuts comic strip. He carried around a blanket. So it's an inanimate object that substitutes for the caregiver when the caregiver's out of the room or away. So it's for separation anxiety. And it's normal for a 4-year-old, let's say, to carry around a teddy bear. But when you're in the emergency room and a 34-year-old walks in carrying a teddy bear sitting down, that's a huge red flag. You can almost make the diagnosis on site. It's called the teddy bear sign. That's not official. That's just what we call it in the emergency room. And I have seen it more than once. And it could also be a pet. It could be a little puppy or a kitten, because those objects and those little animals are not going to abandon the patient, right? They're not going to reject the patient, so they're safe. And in fact, these individuals can feel more comfortable with their transitional objects than they do in interpersonal relationships for obvious reasons. You also see recurrent job loss, you see interrupted education. A lot of times these individuals will drop out right before they graduate, almost as though they're engaging in a self-sabotage. That's how that's interpreted. Just as they may destroy a relationship, sabotage a relationship when it seems to be one that might be an enduring relationship. They sabotage that. They do that also with their caregivers. It's not clear why, but the idea is that these patients don't trust. It's like it's too good to be true. They expect to be abandoned because deep down inside, they know that they're unworthy of it. They never did incorporate that belief that they should love themselves and others should love them, and that they will find people that will give them that unconditional love. And so the idea is that they didn't get enough unconditional love when they were growing up. And see, I used to think, so it's always this nature-nurture argument. And I used to think that it was 100% nurture or 90% nurture. I used to believe that it's because they had withholding parents, that they had a mother who didn't love them, who was emotionally neglectful. And you do see a higher incidence of emotional neglect as well as other kinds of abuse. But I remember one time I was in the emergency room. I was a resident, so I believed this throughout medical school. And then in my intern year, I was talking to a colleague of mine. She was in my class, another intern, another resident, whom I respected a lot. And she said to me, I don't know, I have a sister who is borderline. She is. She meets criteria for that. And we had the same mom. We had the same upbringing. And the way that her sister would describe the way that they were brought up and the way that she was treated was not accurate. It was sincere, but her perception of it, her memory of it was so skewed by whatever it was in her brain that was causing her to interpret things that led her to feel and therefore act like an individual with borderline personality disorder, caused that skewed cognition, those skewed interpretations and perceptions. And that really got my attention. It was one case, but I thought, well, here's one example. All you need is one example to disprove the theory that they all have withholding parents. Here was my colleague who was intelligent. She was a doctor. She was very level-headed, obviously not a borderline personality. She had a good sense of humor. She was in a stable relationship. I mean, she was not a borderline personality, and her sister was, and they had the same mom. And then, of course, besides that, so that got my attention, but there is evidence that there's a genetic influence. Borderline personality disorder is about 5 times more common among biological relatives, particularly first-degree relatives, compared to the general population. And while you see an increased risk of substance abuse and anxiety disorders and depressive disorders in the individual with borderline personality, there's also an increased familial risk of those conditions, as well as bipolar disorder, which has nothing to do with nurture. Bipolar disorder, you're not going to develop manic depression because of the way that you were reared, because of the way that you were treated when you were a child. And interestingly enough, antisocial personality disorder. So you see an increased familial risk of all of those as well in individuals who are related to individuals with borderline personality disorder. In clinical practice, borderline personality is more common among women in clinical samples, but in community samples, you don't see that. It seems to be equally dispersed among the genders. And so that suggests that perhaps there's just a higher degree of help seeking in women as opposed to men. Also, there's been a suggestion that men with borderline personality disorder tend to externalize their symptoms, act out more so than women who maybe internalize their symptoms or turn their symptoms in on themselves. And so there may be more self-injurious behavior, more suicide attempts in women. And that's often what leads a patient into treatment for the first time. And so that might also be part of the selection bias, maybe, and why we think, at least in clinical samples, there are a lot more women than men. So it just may be that men won't go in for treatment even if they are hurting themselves or thinking about hurting themselves. The genetic influences notwithstanding, there is a very high incidence of physical and sexual abuse and neglect, including and especially emotional neglect, as well as early parental loss and hostile conflict within the home. All of those are more common in the childhood histories of patients with borderline personality disorder. And that certainly makes sense if you have a parent who dies or who abandons you, leaves the family, a father who abandons you after your parents' divorce, and then your mother's unavailable. If you were abandoned early on as a child, then that makes sense that you would develop this irrational fear of being abandoned that you've incorporated into your sense of self, and then it permeates all of your relationships. There's also a high rate of reported sexual abuse, and that again is like a red flag for me. In patients with borderline personality disorder, the incidence of reported sexual abuse is extremely high. I mean, it's almost 100%. And that's true in clinic as well as in the hospital. But what's interesting is that these reported rates of sexual abuse are higher in inpatients than in outpatients. And that suggests that a history of sexual abuse is as much a risk factor for the severity of borderline psychopathology as it is for the disorder itself. At the end of the day, the consensus is that a childhood history of reported sexual abuse, there's that word again, reported, this is according to the DSM, is neither necessary nor sufficient for the development of borderline personality disorder. So despite this very strong association that you see clinically in people reporting sexual abuse, as well as confirmed sexual abuse in early life, it's really not a core finding in the history. It's really not necessary. Borderline personality disorder has typically been thought of as an adult onset disorder, which is different from most of the other personality disorders, which must develop by adolescence, most of them early adulthood at the very latest. But this disorder tends to lessen in severity with age. It kind of burns out when a person enters their 30s and their 40s, especially symptoms of impulsivity. They remit most rapidly compared to affective symptoms, which remit at a substantially slower rate. But you really don't see borderline grandmothers. It's rare. Full recovery, which includes good psychosocial functioning, is most difficult, and it's the least stable over time. So if you see a 50-year-old who's still experiencing these rapid, unstable shifts in their affect and their emotionality and unstable relationships and all the other chaos that I've described, then the prognosis is a lot worse for them actually recovering over time. And this lack of recovery is also associated with individuals who are on disability and those who suffer from poor physical health. The differential diagnosis includes other personality disorders and other disorders that include symptoms like dissociation, etc. But the most overlap is with other personality disorders, especially those in cluster B, the dramatic cluster, the so-called wild cluster. But this disorder is distinguished by self-destructiveness, angry disruptions in close relationships, and chronic feelings of deep emptiness and loneliness. That's borderline personality disorder. Thank you for watching.